Michael Clegg talk more about the pathology, and I'll let him have it. It's a little sensitive and slight lag, so just give it a little push.
Okie dokie. Let me start my timer so I don't mess up everything.
You should have it.
It's a habit. Okay. All right. Well, first of all, thank you very much for inviting me to speak today. I'm a bit overwhelmed by how many people have come. I've done several of these sort of talks about different biology and different tumor types, and this is incredibly well attended, which means it must have been incredibly well organized. So props to you. And thanks to Art for showing up, because this is now going to become an international talk on my CV. So I'm gonna call my mom when I'm done and be like the whole world was there. So let's see what I can't. Okay, so you can see what I'm showing over there. So I'll get going. So I'm a pathologist, and we don't often make it to events like this. So what do I do? The clinical teams will see you have a bump. You'll get it worked up by the clinical teams. If you're lucky enough, you'll come to a surgeon like what we have here. They'll take it off, and anything that leaves your body goes to pathology. And pathology is divided into multiple subtypes. We have anatomic, we have clinical. Clinical people do like your blood testing, and anatomic take your tissue. So I'm an anatomic pathologist. I look at slides and make diagnoses, but I'm also a very specialized type of anatomic pathologist. So I'm a bone and soft tissue pathologist. And so I look at mesenchymal tumors, or if there's international audience, I might say mesenchymal, because that's like a sexier word. So I do histologic diagnosis on tissue. I mostly look at soft tissue tumors and bone tumors, which are very rare, as you guys know. And so people like me tend to practice in very large institutions like this because I need a lot of volume to be useful, and those things are rare. I'm also a molecular pathologist. I'm sort of dual boarded. And so like she was talking about with like your DNA and tumor sequencing, I sign those types of reports out as well. So I work at the Children's Hospital here on campus doing molecular sign out for them. And I'm the director of bone and soft tissue on the adult side. So I'm sort of faceted in what I do. So I'm just going to do some brief overview and show you some slides and talk a bit about tenosynovial giant cell tumor. If you have any questions, just raise your hand. I'm very informal. I'd rather you just ask them as you don't understand something, or if I say something weird, just fire off. It's okay. So definition, we usually start with that. These, as we just heard in that excellent introduction, these tumors most often arise from the synovium of joints, bursa, or tendon sheaths, and they show synovial differentiation. It can be classified clinically into intra-articular and extra-articular subtypes, but histologically, which is what we do with our microscopes, we classify them into diffuse or localized subtypes, like she mentioned. There is related terminology, which I like to keep mentioning, because most people were diagnosed with PVNS, and our literature goes really quickly, and we change names a lot. And this is something that we try to keep track of, because a paper you might be reading about your disease 10 years ago is not going to use the same words as today, which means when you Google PVNS, you're going to miss half the literature. And it's something that we have tried to do better at, especially bone and soft tissue tumors have insanely long, ridiculous names. Some of them are very descriptive, and some of them make no sense at all, and they're named after famous people. And so my specialty is really bad at verbiage. And so just something to keep in mind and keep repeating over and over. I'll try to do that when I sign out my reports, to sort of link the nomenclature so everybody knows what I'm talking about. It's hard now. There was a law passed a couple years ago where our reports now go directly to patients, at least in Colorado. I don't know if that's national, but that was a big deal. Like normally I would write a very technical report, I would sign it out, and your oncologist would get that report, ask me questions, and then give you that digested information. And now that stuff, like most patients can just have access to that immediately. The second I click that button on Friday night at 5 p.m., you get a huge report. And so the way we convey this information has become really important. And so please ask away questions if there's things path speak that are foreign. Okay, so like I mentioned, two major types, localized and diffuse. And there's distinction is based on mostly what we see in the microscope. Sometimes surgical, the surgeons will be like, this is a well-circumscribed nodule, and that'd be very helpful. But most of it is what I can see microscopically. As we already saw, these are essentially the differences. Lobulated, well-circumscribed, tiny. Although the size is becoming, I guess, less of a driver of distinction, it's still very relevant pathologically. Localized tumors are very tiny, and you would never see a 15 centimeter localized TCGT. So there is still a breakpoint in there. And the more diffuse the lesion is, the more monotonous it is. It tends to have less complexity, and I'll show you some pictures of that. It's important because the diffuse type can undergo malignant transformation. And when a tenosynovial giant cell tumor becomes secondarily malignant, they're very bad high-grade sarcomas. And that's something that can happen in the diffuse subtype. It's a rare thing that happens in a rare subset. So it's very, very, very rare. But that matters more to us because I need to be very careful with my margins, and I have to look very carefully at this 13-centimeter lesion to make sure there's not 3 cells in there that look wrong. And there's billions of cells in these things. And so it takes a lot of sort of expertise and time to make sure you do that correctly. And it's one of the benefits of coming to a place like this, or I'm sure where most of you have been treated. You really want somebody who does this a lot because those subtle changes can be difficult to identify. All right, I'm going to show you some surgical pictures. There's no blood, but there's an open hand. So look away if you must, but it's a really good photo. So this is a really nice example of a localized tenosynovial giant cell tumor being sort of expertly dissected by a surgeon. You can see it's very tiny, it's very lobulated. It has well margination, which means I can tell where it starts and stops very easily. So can the surgeon. You can see this little cauliflower bump, and it's pretty obvious when that transitions to not the cauliflower bump. When you can outline it. If you can outline it, they can take it out, which is great. Comes out with negative margins and it's essentially gone. It's also, like I said, really well circumscribed. Why is that good? It's because it has a nice hard margin, and there's a big difference between how hard this thing is and how soft your fat is right next to it. And the surgeon can go in, they can very cleanly carve these things out. And so they can get negative margins. And marginal status in soft tissue tumors is a big deal because it determines what things are going to come back, what structures might be destroyed down the line, and things like that. That's to contrast it with a diffuse type. So this is a gross photo of a diffuse type tenosynovial giant cell tumor, or a PVNS. Super irregular margins, right? This thing looks like an octopus. It's all frondy. This is an intra-articular one, and you can see, maybe, do I have a mouse? I could use this. This will work. So all these little tiny little fingers, that's why it was called villonodular, right? Villus has little villi, like the alveoli in your lungs. It sort of has these little finger projections. So irregular margins, and it's really hard to tell where the tumor stops and healthy tissue begins because they're all admixed. And that's hard for me with a microscope magnifying the tissue 1,000 times. It's really hard for a surgeon in the OR trying to figure out how to cut around this thing. And so that's a big deal, and that's why they often have positive margins, because you can't tell where they start and stop, and they also grow into sort of everything. And so it's really, they make sort of tactical decisions. Do we want to cut that thing out? Is the patient better off with that muscle or whatever, or tendon intact, or we're getting that bit of tumor out? And so that's a real difficult decision that they make sort of with imaging studies and all of their expertise. They're also absolutely huge sometimes. And so to scale, that thing I showed you on the last slide is that big compared to how big this thing is, right? That is an absolute monster of a tumor and hard to get out. They're not always like that. There's lots of gray zone, but they can be quite large. So as we heard, these have pathogenic gene fusions between these two genes, the CSF1 gene and most often one of these collagen genes. As she showed, chromosomes 1 and 2. And I'm a molecular pathologist. And so one of the things we do is we sequence tumors to identify if they have this fusion, right? That job, you see that all the time in the news. We're like, oh, we're doing precision medicine. We're sequencing the tumor and looking for the thing. That's really hard in this tumor type for a bunch of reasons. And so I think I want to highlight those so you understand how this is different than all that stuff you're hearing about, like in the news about all these sequences and they found fusions and all these tumors. The tenosynovial fusion is unique, and it makes it way harder to detect. And so in general, when you sequence a tumor, we know what each gene has for a sequence. It's like there's like a registry. This gene has this sequence. And we take a piece of DNA from the tumor and we sequence it. And we have smart informatic computers that can say, okay, we're in gene number 4, sequence changes. And it's like, that doesn't match gene number 4 anymore. Oh, now it maps to gene number 9. Flags us, we might have a fusion event, and then someone like me looks at it. And so in this case, part of the CSF1 gene and part of the collagen gene get put together, and the informatics will tell me we likely have a fusion between these two things. That's how it normally works. It's a little bit more complicated in this tumor. So genes are driven by things, right? You've got thousands and thousands of genes in your body, and they're all not turned on all at the same time, right? They're doing certain things. You cut yourself, your body has to regrow tissue to fill that scar in. Collagen genes get turned on. And so genes run at different speeds based on what they do in your body. The CSF1 gene is relatively slower on that spectrum. So an analogy would be a train. So the CSF1 gene is very slow. Its promoter, the thing that pushes it forward, is relatively wimpy. And so you don't get a lot of CSF1 product most of the time. It's doing whatever it needs to do in your body, and that's fine, but it's on the slow end of the spectrum. Collagen genes are everywhere in your body, your hair, your skin, your bones. They're very highly driven. And so if you think about gene fusions, it's this part of a gene grabs this part and becomes a special new thing. That's not what happens in this tumor type. The CSF1 gene is intact. What it does is it takes that steam engine from the front of the collagen gene and brings it and puts it in front of it to drive it faster. When we sequence tumors, we mostly look at the exons, the part that codes, the thing that matters, because your DNA is massive and almost none of that does anything. So we just sequence the parts that we care about. And so if you just sequenced any of your CSF1 genes, it's going to be totally intact and totally normal. You have to go outside of that coding region to find where this weird promoter has been brought in. And so what you end up with is something that looks like that. We take the jet engine off of the collagen gene and it gets stuck in front of the CSF1 gene and it drives it way harder than it should. I mention that because most of the time when you do sequencing, we don't sequence every single bit of your DNA. We sequence targets, and they often don't go out into the weeds. And this swap happens out in those weeds. And so unless you're looking for it and know what you're doing and are very specific about how you design the test, you're not going to detect it. So you have to go into the intron, so upstream of where this gene exists, to see this little sneaky swap that has happened. And 99.99% of sequencing studies don't do that because it's not typically what things do. Most of the time, it's half of this gene becomes half of that gene, and they make some super, chimeric Spider-Man gene, and they go crazy. This is different. This is changing the engine in the car, and we don't look for that most of the time. So that's one of the complications. I'll show you one sort of biology slide about what happens with this, and I'm just going to sort of break it down into ways that make sense. Number one, because of this swap, the tumor cells are making too much CSF1. Okay, step one, that's what happens. Some cells in your bodies have CSF1 receptors. They pick up on that signal and they get recruited to the site of your tumor. The result is a recruited landscape of reactive inflammatory cells hanging out with your couple tumor cells. And so unlike most tumors that just grow insane, they divide like crazy, and it's all the same thing, you have some cells that are bringing a massive party to it. And that changes the way the tumor looks to us, but also what happens when we try to sequence it. And I'll show you that. There's a bunch of other things that happen, and the downstream effect is a lot of things get turned on. Your joints swell, you get bone and cartilage destruction, as well as getting more cells recruited to the site of disease. And this is the part where I'm not an expert. There's all sorts of targets that you block these different things. That's where my expertise stops. You always want to trust your doctor. That's not me. Like, you do not want someone that wiggles into other areas of specialty, and I will just shut that down hard. Family members, I'm like, you need to see an otolaryngologist. And so even in pathology, I have my bounds. I'm exceptionally good at a couple things and super not at others. If you got a weird mole, that's not me, super not me. And so the better your doctor is, the more they're going to be like, let's get the expert down the hall because they know more than I do. And I draw the line real hard at special drugs targeting the pathways. Okay, so most tenosynovial giant cell tumors will have this fusion. Most of them have it. It's hard to test for because it's that odd fusion, right? Like, it's weird to begin with, but it's also a minority. So what happens? We take one of your tumors and you want me to sequence it and look for a fusion, right? I take your tumor and what do I do with it? I grind it up like in a blender. All the DNA goes out into the world, and then I sequence that giant pile of stuff. But what am I grinding up? I've got one tumor cell for every 500 lymphocytes that have been recruited to the site. They all get ground up. So when I sequence that DNA, I'm mostly getting the normal stuff. It's mostly the normal stuff your body has brought in and not those tumor cells. So you can think of it like voting. Like, this little blue dude's vote is not going to matter because it's being drowned out by everybody else. That's what happens when we look for your sequence. And so if you think of 100% of your DNA gets sequenced, how much of that is the part that you care about for your tumor? And these things, it's like 1% or 2%. So not only is this weird, but the signal I'm looking at is almost non-existent because of all the background partying that's going on with all the other cells. And so what that does is it leads to false negative testing. So even if they know what they're doing, our assays have sort of an area where we're allowed to report them. I need to see a signal at least this big to know it's not noise or a mess up of the assay. And so 5%, 10% of a signal is what I need before I can say it's real. Because these things really matter. Like I get the sample and I'm giving somebody a diagnosis of something crazy rare and often crazy bad. And I give that to the oncologist and they're like, okay, we're getting chemo. And it's because of a result I got out of a test like this. You know, a lot of things, but that. And so the signal you're getting here is so small that our assays will mostly throw it out. It's so low as to be noise. And so even if you get the test you want and you get a place that can look for it, you're often going to get a negative result, even if everybody's amazing at their job and they do the best thing they can. Those other things you can do. So like I'm saying, you know, sequencing is often not good. We can do stains. So there are certain protein stains that pick up these targets. I look at a slide, I see the brown. That brown wouldn't be there unless the signal was there. And so that's helpful. I can look at the tissue and see what cells. You can also do FISH, which is a fluorescent way to look at probes on certain parts of genes. And so like I said, or she showed in the little caricature, the genes get swapped, right? So you can see when one of those chromosomes gets broken, if I've got a tag on this side and a tag on that side and it gets broken, those dots are going to separate in space. That's what you see here. We have overlapping dots. That's a normal copy. And we've got this little green dot out by himself. That means somebody had to have been pulled off and the break happened. And so you can do that. Same issue though, is that you have to know what cells to look at, right? To see that one cell that's surrounded by 500 other ones that are totally normal. And they also have reporting thresholds. Luckily, we don't need these things. I don't need these things to make the diagnosis 99.9% of the time. So specialized pathologists make these diagnoses all the time. And so I can look at a slide of a TGCT and I will know that's what it is almost as fast as my eyes focus, maybe 2 seconds. I'm like, yeah, that's what that is. It's very characteristic. We see a lot of them. And so needing these specialized tests is almost never a thing because I see them and I can recognize it. And that's my job. And so like most of the time I don't order this testing. When will I order it? Wrong situation, something crazy aggressive is going on. Patient is crazy, which is okay. Sometimes people need it. They need that extra test. They've read about it. Sure, why not? We'll try. With the caveat that it might not work and we educate. But like 99% of the time, I don't need this. And so we almost never do ancillary testing in these tumors because I can just look at it and see that's what it is. This is a good example of a tenosynovial giant cell tumor. And I'm going to just show you a couple of the cell types that are in here. So all of those different types of cells are in this slide. And that's a problem when you're trying to figure out what's going on. Foamy macrophages, they get recruited. They're histiocytes. Sometimes they get hemosiderin and they become the hemosiderin-laden macrophages, like she mentioned. Big foamy cells, perfectly reproducible, easy to diagnose for me. It's a nice finding because it's one of the things I expect to be here. It's very comforting. There's giant cells, these multinucleated cells with multiple nuclei inside one cell. So that's one cell. Fibroblasts, these are sort of supporting structural cells. None of these are tumor cells yet. Lymphocytes, you know, one of the things that like fights off the flu virus, they get recruited in. There's tons of lymphocytes. Every single lymphocyte drowns out your signal by half, and a lot of them come in. There's also a couple little red blood cells, just for completeness sake. These have blood. And tumor cells. So I'm pretty confident those two are tumor cells. They sort of lack cytoplasm. They have a bigger nucleolus, you know, whatever. There's things that make me think that those are lesional, but they're hard to pick out. They're a real minority in this thing. So imagine throw this thing in a blender and see which signal comes out. It's not going to be from those two cells. It's going to be from this mountain of foamy histiocytes over in the corner. There are certain stains that can highlight the very specific tumor cells. This is a clustering stain, and it's just sort of showing you those are CSF1 producing tumor cells. So I know for sure every brown dot on there is a tumor cell, but every blue dot isn't. And it's hard for your eye to pick it out, but there's like 1,000 to 1 blue to brown dots on here. The brown ones are big and they look exciting and they catch your eye, but there's a lot more blue cells in there. So you can do that. It's sort of nice to know. You know, I read this study and I'm like, okay, these cells are really rare. You know, I sort of do my job better. So clinical implications. What happens when you get a biopsy of one of these tumors? We'll take this little localized one, for example. What does that look like when it comes to somebody like me? Surgeon sticks a needle through it, right through the middle of it if we're lucky. I get that little sliver. What can you do with that little sliver? I'm talking about size and margins, and is it going to be malignant over in the corner? I don't get any of that information. And so what you're going to get is a descriptive diagnosis compatible with tenosynovial giant cell tumor. I'll put my hands in the air and be like, see my comment. And I lay that kind of stuff out. I can't tell you if it's localized or diffuse, how big it is, how bad it is. I can't do any of that until I see the whole thing. And so you'll get these very sort of wispily worded things, but that's because I can't rule out those possibilities and I don't want to be wrong, right? The surgeon will be like, this is localized, it's tiny. He'll probably tell you that, or the clinical team will, and that's fine. I have to use the data that I have and be perfectly precise because I can't be wrong ever. And so you'll get these caveats. If I don't see the whole thing, I can't tell you if the edge of it evades into a bone or something. And so we get these sort of cagey diagnoses. If you're good, that's what you want. You want a pathologist to throw down a report like that because that's accurate. Localized lesions, they come out completely, the surgeons get around them, and they usually don't recur. The diffuse type is much more of a problem. The margins are often positive because they're hard to tell where they stop, and they also go into things they don't want to cut out sometimes. They can recur many, many times. I'm always worried about progression to malignancy. It's incredibly rare, like I said, but it's something that I need to keep track of. And one of the most important things I can do is be on top of that when it happens. The earlier you pick something like that up, the better, right? I don't want to make that diagnosis when it's metastasized somewhere, because then it's a fully malignant bad thing. But if I can find one little focus of it that is doing that deep inside of a tumor, we can make that diagnosis and your therapies can change before it becomes an issue most of the time. Like I said, this is very rare. I don't know. I don't want to freak anybody out. It does happen. It's something I worry about because it's my job to not miss that for y'all. It's usually like multiple occurrences, like the 15th time it comes back, you get like a little bit worse and it suddenly a mutation pops in and it becomes a bad thing. Clinically, they suspect this because suddenly it comes back really quick or it's really painful or something like that. I always like to show this. And so they become a different animal. And so this is a mitotic division. So the cells in your body divide, right? Like that's how you grow. And how that works is you get one cell, it duplicates all of its DNA because it needs to split in half. It lines up into a perfectly flat line, all cute with all the chromosomes stacked, and they go like this. And it pulls apart, and now you have two cells. That's how it's supposed to work. A whole bunch of proteins are involved. They have these little structurals that pull them apart. And it's quite a pretty little thing you can see in a cell. When these tumors go bad, they pick up mutations in the things that do that. And so they lose the ability to be all cute and line up and do this. They become chaotic and they go in 1,000 different directions at once. And so if you see a cell that's pulling apart in 10 directions, I know it is genetically really messed up, which that can't happen in a benign lesion. It has to be full of mutations. And so this is a malignant tenosynovial giant cell tumor here. And this is a diagram of what that cell was doing. It's pulling in 25 directions at once in this giant ring, and you can see it on the slide. That's the kind of thing I'm looking for. I'm hunting for that one little dot that looks like that, because I'm like, that shouldn't happen ever. And if it's happened, I know that cell has mutations this tumor shouldn't have, which means something has changed. We could sequence it again and try to find that mutation. And the sequencing is usually better at that point because they become much more pure because they're on the road to being just a high-grade malignant thing. But that's the kind of thing that I have to look for. So that's a messed up mitosis. That's bad. I'm now going to show all my colleagues. We're going to have a big meeting and make sure that we all know what we're doing and I make the correct call. But that's the kind of thing that I look for. So these are very odd tumors. They're comprised almost entirely of reactive cells. There's not a lot of tumors in the body that will do that. Most things you hear and read about are going to be clonal proliferations of like one cell type. Adenocarcinoma, squamous carcinoma, melanoma, most sarcomas, fibroids, they're all sort of clonal proliferations of the same thing. For I guess known, but unpleasant reasons, this CSF1 gene strongly recruits inflammatory cells to the site, which is a problem because it comes with all the inflammatory stuff, all the inflammation and all the nonsense that you get from all these inflammatory cells. But it makes all the testing more difficult. It makes diagnosing them more difficult. It becomes a much harder thing to be confident about. The differential diagnosis is very wide because now I have all this inflammation. I'm like, well, is it lymphoma? Is it just a crazy synovitis? And so it's much more difficult because of the specific molecular biology of these tumors. They're weird. They're very unique in the way that they activate themselves, and that creates all these unique challenges. They exist on a clinical spectrum of, essentially benign, they get cut out, they don't come back, to locally recurrent, huge sort of pain in the ass tumors that just like keep coming back, and you're always like, why? To, in some rare scenarios, very, very bad things that flip on a switch. It's very remote, it's very tiny, but I'm scared of that. And so that's what I raise as one of the things to talk about. And pathology plays a real key role in diagnosing these things and diagnosing all the things, right? The surgeons and the clinical teams, they know what you've got before it comes out of your body, right? They're like, oh, this is going to be a PVNS or whatever, because they're exceptionally good at reading the imaging and seeing it grossly and doing all of those things. But you can't really do anything until a pathologist like stamps that as that's what it is. And that's why we work together as a team so much. We have these giant tumor boards and we have 50 experts all at once, and we argue about all these things, and you get a much better product for your patient care. The ancillary testing is a big thing for you all to understand. It's like you'll go online and you'll see these articles about this gene fusion, all the testing you can do and all the things that they can find. Why did my tumor not have that? Why didn't they do it, and why was it negative? Like all these questions come up in your mind. Most of the time, I don't need that testing to make my job work, but sometimes the oncologists do for a clinical trial. They want to give you a drug and they have to have that molecular information. So we will do it in that scenario. Sometimes those things will still be negative simply because we can't get enough signal. We can't see it even though it's in there. So just be aware that's a thing, and hopefully now you understand a little bit better about why that might be the case. It's not because the lab's bad or they messed up. It's because it simply can't be found in some scenarios. And when it's not a tenosynovial giant cell tumor, like if it's not a TCGT they take out, the diagnosis on my side is real complicated real fast. There's probably 200 other entities I need to be able to recognize that it could be instead. Some of them are totally benign and some of them are super not. And so when it's not, it becomes complicated. But luckily, we see these things enough, and especially in these centers like this, that typically the diagnosis is not the hard part. It's the treatment side and dealing with the surgeons, dealing with them, but like working with your colleagues, the surgeons, to get the right therapies, and that's the hard part. It's not really on the pathology side most of the time, especially for a place like this. I will take any questions about any of that.